Hello everyone, so good evening. This week we'll be continuing our series on biologicals which are used in psoriasis, and with Secukinumab this week we'll be completing the FDA approved biologicals which are used in psoriasis. So make sure you go back and see the previous video so that you will understand how sequentially we are going. Initially we discussed the pathomechanisms of psoriasis, and with that, we came to know that the key initial mediator is TNF alpha, followed by interleukin 23, followed by interleukin 17 axis. And that is why we are discussing TNF alpha first, followed by Secukinumab, which is 1223 interleukin inhibitor. And this week, we'll be discussing Secukinumab, which is interleukin 17. Just let me write it again. It is interleukin 17 inhibitor. Okay, so if you recall, and if you have seen or went through my presentation on pathomechanism of psoriasis, you would understand why we are discussing it this way. So it starts with TNF alpha, which in turn activates interleukin 23, which in turn activates interleukin 17. Now the action of interleukin 17 is basically on two cell lines. One is keratinocyte and the other are neutrophils. Keratinocyte will lead to plaque formation that we see in psoriasis. Neutrophil will lead to neutrophilic inflammation. Both of these are seen in psoriasis. Okay, so now you remember why interleukin 17 axis is the major predominant axis used or is in use in pathomechanism and the pathological process of psoriasis. So are we clear with that? Today we are going to discuss what is Secukinumab, how does it act, and what are the uses, the dosing regimens in psoriasis, and what are the adverse events and contraindications with Secukinumab. With that, we'll begin this series. Now, Secukinumab is a recombinant fully human IgG1 kappa class, IgG1 antibody, which is against interleukin 17A, thereby inhibiting the attachment to its receptor. Okay, so let's see it word by word. What we mean by fully human? That means it is made through human cell lines, and it is made. It has the least amount of interaction in the sense that when we inject Secukinumab in the patient's body, the body kind of takes it in better than other biologicals or other TNF alpha inhibitors, and the auto drug antibody formation is very low. IgG1 kappa class antibody to interleukin 17A. Now, interleukin 17 is the star molecule of this presentation, and every discussion will be around interleukin 17. So interleukin 17 group of interleukins there are 6 different interleukins in interleukin 17 family, and they are coded from letter A to F, and the receptors attachment is inhibited when Secukinumab attaches itself to interleukin 17. We'll discuss the mechanism of action of Secukinumab subsequently when we'll be discussing the mechanism in detail. Now, it has been approved for moderate to severe psoriasis in 2014, and it is one of those few indications where a biological has been approved for psoriasis first and then approved for rheumatoid arthritis or other non-dermatological uses. Okay, most of the time in the previous presentations we have seen that the biologicals were approved for other indications first, and then subsequently their use have been found in psoriasis. But like Ixekizumab and like Secukinumab, these biologicals were first FDA approved for psoriasis and then subsequently for other indications, namely psoriatic arthritis and angst-spawned rheumatoid arthritis, nail psoriasis, and pustular psoriasis. Okay, palmoplantar psoriasis also. So they are manufactured using Chinese hamster ovary cell line. Now, what do we mean by that? So, as we have said that it's a fully human IgG1 class of biological. That means human DNA or modified human DNA which encodes for protein structures which will subsequently form Secukinumab is taken out and inserted in Chinese hamster ovary cell line. And when this Chinese hamster ovary cell divide and proliferate, this human DNA also gets proliferated, which encodes for secukinumab. So when this proliferating DNA gets translated into protein, it forms secukinumab structure, and that is why it's a fully human biological, but it is created using Chinese hamster ovary cell line. Clear? The doses in which it is available is 150 milligram. It is available in vial form. Now, most of the time, or most of us have seen secukinumab in a vial form. This is somewhat in contrast with previous biologicals in which we have auto-injecting pens or syringes. The syringes and auto-injector pens are also available, and each of these pen has 150 milligram each. But since most of us have used vials, we'll be discussing vials a little bit in detail as compared to auto-injector pens. But I reckon that in future, or in maybe right now also, these pens will be easily available, and it will be easier to see those pens rather than those vials. But since I used to administer it in a vial form, so I think it will be better to discuss vials also in detail. Now let's discuss the pharmacokinetics of secukinumab in detail. The bioavailability is 55 to 77%. Remember that all biologicals which are given through subcutaneous route will have a bit lower uh, bioavailability. So in the case of secukinumab, it is 55 to 77%. While in IV infusion biologicals like infliximab, the bioavailability reaches about 93-94%. So remember that the route of administration is responsible for bioavailability. It's one of the major factors of bioavailability, and that is why secukinumab is given in subcutaneous route. But if it is given through IV route, the bioavailability increases very much. In one of the articles, I have read that absolute bioavailability is around 73%. So this is also one data that you may remember. Okay, but the range is from 55 to 77. Peak concentration is reached in 5 to 6 days after the first dose. T half ranges from 22 to 31 days, average of 27 days. Okay, so remember it's roughly about 4 weeks, and you will remember 4 weeks when we will discuss the regimen in psoriasis. The metabolism and excretion is unknown like all other biologics, but remember that it's an IgG1 based biological, and like all IgG1 molecules in our body, it gets degraded into amino acids which get secreted in through kidneys. So very bad looking kidney, but remember that that is how people postulate how secukinumab is excreted from the body. However, it is said that it is minimally excreted through kidneys, so that is why it still remains unknown, but that is one of the postulates. Now, anti-drug antibodies. Remember that these are all exogenous proteins which are injected directly into the system. Clear? And whenever an exogenous protein gets injected into the system, it will lead to formation of some antibodies by our immune system, and these are known as anti-drug antibodies. In the case of secukinumab, since it is a fully human IgG1 class of biological, the percentage of anti-drug antibody is very low, it's less than 1%, and even half of this is neutralizing, and that is when we are reading it after 1 year of administration. So we can clearly see that the anti-drug antibodies are very low, and in spite of being low, only half of them are neutralizing at the end of 1 year, and thus we can clinically also see it as no loss of efficacy. Remember the presentation on infliximab. Now infliximab is a chimeric antibody, okay, chimeric biological made by combining murine, which is rat or mouse genetic material with human genetic material. Okay, now because of its chimeric nature, it is recognized as a foreign protein molecule by our body, and a lot of anti-drug antibodies are made, and these anti-drug antibodies are going to neutralize infliximab on subsequent exposure. But on contrast to secukinumab, when we give secukinumab, the anti-drug antibodies are less than 1% and half of them are neutralizing. That is why on subsequent exposure to secukinumab, we don't see much loss of efficacy. And that is also precisely the reason why we do not combine secukinumab with methotrexate. But remember that in infliximab we give methotrexate, to neutralize those antibodies. But with Secukinumab, there is no need of giving methotrexate because the anti-drug antibodies is less than 1%. You're clear on that? Okay, so let's move forward. So that was for the introduction of Secukinumab. We will discuss a bit in detail how it acts. For us to understand how Secukinumab acts, we need to know a bit about interleukin-17, the star molecule of this presentation. Remember that initially in psoriasis, it was thought to be a Th1 mediated disorder. But subsequently, with further research, we have found that it is actually much more relying on Th17 cell classes. So Th17 cell class is different from Th1 and Th2 cell lineages, and Th17 is responsible for secretion of interleukin-17, which is the major molecule we will be discussing today. Now, interleukin-17 family of interleukins have 6 types of interleukins ranging from A to F. There are 5 kinds of receptors ranging from A to E. Okay, so let's not confuse ourselves. There are 6 types of interleukin-17, interleukin-17 A, B, C, D, E, F, and there are 5 different receptors for interleukin-17 ranging from A to E. Clear about it? The major action of Secukinumab is on interleukin-17A, and we are talking only about the interleukin, not the receptor. Interleukin-17A is the major site of action for Secukinumab. We are clear on that? Now remember, on the first slide we discussed that the major action is on keratinocyte and neutrophils. So it is responsible for neutrophil mediated inflammation. Okay, it is responsible for the chemotaxis, or let's say calling neutrophils towards the skin. It is responsible for neutrophilic mediated inflammatory action at the site of inflammation, which is the skin. Interleukin-17 has found to be increased in serum and in skin, and the increased levels correlate with disease severity. Clear? One additional mechanism of action is that because of interleukin-17, there is upregulation of rank ligand. Now remember that rank ligand its major action is in the bony structures, where it increases the action of osteoclast, and this is the mechanism where it has been found to be implicated in rheumatoid arthritis, psoriatic arthritis, and even in angstrom. Okay, so interleukin-17 has 2 cell lineages, one on keratinocyte, other on neutrophils. When it acts on keratinocyte, it increases the proliferation of keratinocytes, making the psoriatic plaque. When it acts on neutrophils, it increases the migration of neutrophils from the blood to the skin, leading to neutrophil mediated inflammation. And it has a third action on rank ligand mediated action on osteoclast, where it leads to joint space destruction, leading to arthritis like rheumatoid arthritis and psoriatic arthritis and angstrom. You clear on that? For us dermatologists, it is majorly on keratinocytes and neutrophils. Clear? So let's move forward and discuss. Now this is the same slide which I have taken from my presentation on pathomechanism of psoriasis. So if you are still unclear about how does psoriasis form, the psoriatic plaque is formed, I request you to go back and see again the pathomechanism of psoriasis video, and you will be able to better understand how are these cytokines acting and how are we getting relief by inhibiting them. So as per the current theory, the destruction of keratinocyte releases a lot of antimicrobial peptide, pathogen associated microbial proteins, and damage associated microbial proteins, so PAMP, DAMP and AMP. So all of these are secreted, and these are just the name of few of them. I go in detail regarding each of them in the pathomechanism of psoriasis lecture. Okay, now we'll take this pathway this time. So by the maturation of myeloid dendritic cell lineages, we secrete TNF alpha, which we discuss in first biologics, interleukin-23, which we discuss in Ixekizumab, and the interleukin-23 is responsible for maturation of naive T cell to form a Th17 cell line T cell. Okay, so a naive T cell which has not yet differentiated into different cell lines, under the influence of interleukin-23, TGF beta, interleukin 6, interleukin 1 beta gets modified into Th17 cells, and this is the major acting cell as far as Secukinumab is concerned. Clear? Now this Th17 cell will further secrete interleukin 17, interleukin 22 and TNF alpha. Remember that TNF alpha is one of the star key mediators in psoriasis, and interleukin 17-22 axis is the major axis of inflammation in psoriasis. So this TNF alpha is the one that starts everything, the pathomechanism of psoriasis, and interleukin 17 and 22 axis is the major axis of inflammation in psoriasis. I go much in detail in the psoriasis video, so go back and see that. Okay. Now what do we mean by increased activation of Th17 cells? Now when Th17 cells are increased in activity, they will secrete a lot of interleukin 17, and this interleukin 17 is responsible for aberrant keratinocyte activity. So these keratinocytes are activated in the presence of interleukin 17. There are other immune cells, namely neutrophils, which are activated and are called upon the site of inflammation, which is the skin, under the action of interleukin 17. Now when keratinocytes are activated, it will lead to increased proliferation, which itself will lead to hyperkeratosis. So interleukin 17 will act on keratinocyte, will lead to formation of keratotic plaque in psoriasis. Clear? Interleukin 17 will also lead to secretion of interleukin 8, which is a very major neutrophilic chemoattractant. So it's neutrophilic attractant, that means it will attract neutrophils from the blood vessels to the psoriatic plaque. So interleukin 17 is calling neutrophils, it is making thicker keratinocyte plaque, and it is increasing interleukin 8, which is further calling neutrophils. Th17 are also secreting TNF alpha. With TNF alpha, we can go back and give a positive feedback mechanism and further increase all the cytokines and chemokines in psoriasis. Okay, so eventually when we started from keratinocyte injury, subsequently we have reached Th17 cells, and because of Th17 cells, the whole cycle gets amplifying with every turn, and this is known as feed forward mechanism. So because of interleukin 17, this mechanism turns into a positive feedback loop, and thus the inflammation keeps on increasing and psoriasis keeps on increasing clinically. We are clear on that? So now we have understood how does interleukin 17 act, and blocking interleukin 17 by using Secukinumab puts a stop to all this pathomechanism inflammatory pathway, and you have relief in psoriasis. Clear? Let's move forward, and from the next slide we'll be discussing regimen to be used in psoriasis. So after learning about how the Secukinumab will act in patient of psoriasis, we'll now learn what is the regimen to be used at psoriasis. For adults, the dose that has been recommended is 300 mg, which we give at week 0, 1, 2, 3, 4. So we give 5 doses 1 week apart. This is known as the induction phase of Secukinumab. Okay. This is the induction phase. After giving induction phase, every 4 weeks we give 300 mg, and this is known as the maintenance phase. Okay. So induction phase 5 doses, every dose 1 week apart. After that, every 4 weeks you give 300 mg, and that is known as maintenance phase. Clear? Now each box is 300 mg of Secukinumab. Now remember that auto injector pens and the syringes have 150 mg. That means when you are giving 300 mg, you have to give 2 of those syringes. So subcutaneously 2 injections at every visit. So we give 1 at 0, 1 at 1 week, 2 week, 3 week, 4 week. Now this is the induction phase completed. After that, every 4 weeks you will give 1 doses subsequently till the psoriasis gets resolved. Okay, now this is the regimen to be followed for Secukinumab. When you follow Secukinumab, it has been found that at week 16, this is the point where you will assess. So by week 16, what do we mean by that? Induction phase is complete. Then at 8, 12 and 16. So at week 16, we'll see PASI 75, and PASI 90. So PASI 75 means 75 reduction in the PASI score as compared to baseline. PASI 90 is 90% reduction in PASI score as compared to baseline. It has been found that roughly 75 to 80% of patients will have PASI 75, or they would have achieved PASI 75 at week 16, while roughly 55 to 60% of patients would have achieved PASI 90 at week 16. Okay. Now it has been found that since the dose recommended is 300 milligram, people have also used only 150 milligram instead of 300 milligram. So that has been, if we replace 300 milligram with 150 milligram, half the dose, the response is acceptable, although not as good as 300 milligram. And it has been found that when we stop Secukinumab, the relapse rates are higher with 150 milligram. So if, let's say, after giving Secukinumab for multiple months, multiple weeks, now we have stopped Secukinumab. It has been found that relapses occur at week 12 after stopping if we use 150 milligram, and it occurs at week 18 after stopping if we have used 300 milligram. Okay, so if it is 300 milligram, relapses occur at week 18. If it is 150 milligram, relapses occur at week 12. For psoriatic arthritis, it's the same regimen that we use here, but replace 300 milligram with 150 milligram. Okay. If adequate response is not seen with 300 milligram 4-weekly maintenance dose, some articles mention that it can be given at week 3 interval also. Some mention that it can be given at week 2 intervals also, and some say to replace subcutaneous doses with IV doses of Secukinumab. Clear? So let's move forward. Isolated case reports have also found to be mentioning its use in palmoplantar psoriasis, pustular psoriasis, nail psoriasis, and it has found that significant reduction occurs clinically in DLQI parameters and well-being quality of life of the patients, and also when measured objectively by using NAPSI scores or pustular psoriasis PASI index or palmoplantar psoriasis PASI index. These are all specific specialized indexes to look at clinical improvement in these parameters, and there are significant objective reduction in those parameters. Other disorders which you can mention in your viva are hidradenitis suppurativa, chronic non-infectious uveitis. One of the major causes of these is Behçet's. Other neutrophilic dermatosis. Now remember that interleukin 17 plays a very important role in neutrophilic chemotaxis. So if we block interleukin 17, the neutrophils are not able to migrate at the site of inflammation, and thus its use in neutrophilic dermatosis have been justified, predominantly involving Sweet syndrome and pyoderma gangrenosum. Other lymphocytic based inflammatory disorders like atopic dermatitis, lupus, pityriasis rubra pilaris also. PRP is not lymphocytic based. So atopic dermatitis, lupus, these isolated case reports do exist where use of Secukinumab has led to significant clinical improvement. So now we have discussed what is Secukinumab, how does it act by blocking interleukin 17, and what is the regimen to be followed in psoriasis. Now we'll discuss the practical aspects of giving Secukinumab. How do you actually administer Secukinumab in your patients? Okay, so if you're using a vial, never shake the vial. Remember that for any biological, you're not supposed to shake the vial or the injecting syringe or the pre-filled pens, because it's a proteinaceous molecule. It will lead to frothing. The structure may get damaged with a lot of manipulation, and it will not have its good efficacy. Examine the vial or the pen or the syringe for particulate matter. It has to be stored between 2 to 8 degrees Celsius in a refrigerator. Store in the original carton in which it comes. Protect from light so that there is no photo degradation. Do not freeze. It has to be kept between 2 to 8 degrees Celsius in refrigerator, not in the freezer. Do not freeze. And if it gets frozen, you cannot use it. Okay, so if it gets frozen, don't think that you will thaw it out, it will become liquid again and you can use it again. No. Once it gets frozen, do not use it. Discard the vial, use another vial. Do not use after expiration date. You clear on that? Baseline investigations include the same CBC, LFT, KFT, ESR, CRP. I would like to say that it's good idea to always add ECG also to look at the cardiac functioning. Urine routine microscopy to look at any signs of infections. Now, you have to screen for tuberculosis in a country like India where TB is endemic. But remember that the incidence of activation of tuberculosis is very high when you're using TNF alpha inhibitors, because remember again, TNF alpha is responsible for granuloma formation. If we block TNF alpha, granulomas are not formed. The tuberculosis which have been lying latent because of granuloma gets released, and that leads to TB reactivation. But since in Secukinumab we are blocking interleukin 17, not much role in TNF alpha. Although theoretically interleukin 17 blockage can block TNF alpha, because remember the flowchart which we were discussing, that interleukin 17 has a feed forward mechanism and TNF alpha is also secreted by interleukin 17. But the activation of tuberculosis has not been found much. And there have been multiple studies in psoriasis patients with different dosing regimen, different duration of therapies, and none of them have shown reactivation of latent tuberculosis. So interleukin 17 inhibitors, namely Secukinumab, is safer in patients who have a latent or who have a let's say the tendency of reactivation of tuberculosis is lowest when we are comparing biologicals, okay, or towards the lower side when we are comparing biologicals as compared to other common biologicals like adalimumab or infliximab or etanercept, okay. But we need to screen for any active tuberculosis, because then it becomes an active infection, or any foci of latent infection in which you would like to give a prophylaxis for TB, then you give biological. We'll be discussing this again when we'll be discussing TB and secukinumab. Biological markers, HIV to look for any associated immunosuppression. Any other sign of infection has to be thoroughly investigated so that we cannot give biologicals if there's any active infection present. So now you have a patient of psoriasis in which you want to give secukinumab. You have secukinumab. Now what to do? Take it out of the fridge and keep it for 15 to 30 minutes so that it reaches room temperature before injecting. Inject within 1 hour after removing from refrigerator. Okay, so the moment you remove from refrigerator, the clock starts and you have to inject within 1 hour. Do not remove the cap or cover. Remember that in all pre-filled syringes or auto injector pens, the cap has to be removed just before you are injecting, okay, to prevent needle stick injuries. Inspect for any particulate matter discoloration prior to any administration. The biological does not have any preservative. That means if there are any unused portion, you have to discard it completely and inject full amount. We are clear on that? Let's move forward. Now it comes, if secukinumab vial is being used, it comes in a 6 ml vial, and in that vial you will see a cake of secukinumab, a lyophilized cake, and in this you add 1 ml of sterile water. Now remember, let me just make it again so that my point is clear. Whenever you're using a biological in the form of a vial and not an auto injector pen, okay. So let's see, here you have a vial of secukinumab, and this is the secukinumab cake. Whenever you're diluting a vial with a biological, do not push the jet of water directly on the cake, push it on the wall, okay, so that you don't damage the cake. Fill it with 1 ml of sterile water and let it mix. Now, there is a unique way of mixing secukinumab, or for any biological for that matter. You take the vial, you inject 1 ml by directing it towards the wall, not the cake. Then you tilt the vial 45 degree and gently roll it between fingers for 1 minute. Okay, just keep on rolling it like you're rolling a dice. So let's see if this pen is the vial. You just roll it between fingers at 45 degrees for 1 minute. Do not rotate, do not shake the vial or you will destroy the protein molecule. After rolling it, you keep it aside and let it stand for 10 minutes. After 10 minutes, you roll it again for 1 minute and then again roll for 5, let it stand for 5 minutes. After that, you use it immediately. If you are not able to use it immediately, you can keep it in refrigeration for 24 hours. So let's revise. You dilute it with 1 ml sterile water, tilt at 45 degree, roll between the fingers for 1 minute, not to rotate, not to shake the vial, okay. Allow to stand for 10 minutes. After that, roll again for 1 minute, then again stand for 5 minutes. Inspect it for particulate matter. Use immediately, or you use it within 1 hour of taking it out of the fridge. If you are not able to use it, you can keep it back in the fridge for 2 to 8 degrees Celsius for maximum of 24 hours, that is 1 day. So for example, you have reconstituted the vial, it has to be used within 1 hour of removing from fridge, or you keep it back in fridge and use it within 24 hours of reconstitution. We are clear on that? So here we are seeing Cosentyx auto-injector pen of 150 milligram each. So if you are giving 300 milligram, you have to give 2 injections at one instance. Or here we can see Scafos. No, most of us will be familiar with the brand Scafo as in Cosentyx, and this is the vial that we used to formulate or dilute with sterile water and then inject in the patient. Now the injection technique is same as any other biological that you give through subcutaneous route. You inspect for particulate matter, allow it to thaw, remove the rubber cap, inject at 45 degrees by pulling up the skin and injecting it into subcutaneous tissue. Now this diagram I have taken it from the adalimumab presentation, but it's just to show how to inject. Just pick it up and inject it at 45 degree angle into the subcutaneous. Now these are the injection site. This I have taken from the Ixekizumab video. Most of the time it is the upper outer arm, the lower abdomen, buttocks, or the anterior of the thigh. Now remember that you have to give 300 milligram Secukinumab. So in 300 milligram Secukinumab, you have to give 2 injections of 150 each. So you have to use it 2 different sites. So one leg, other leg. Keep on rotating the sites every time you inject. So the concept for injectable biological remains the same. That you have to use 2 different sites. You have to keep on rotating the site. You have to mention what site you are injecting at what instance, and you cannot inject if the site is red, bruised, inflamed, erythematous, firm, tender, or if it has a psoriatic plaque on that. Okay, so you cannot inject on those sites. We have learned what is Secukinumab, mechanism of action, regimen in psoriasis, and how to administer Secukinumab in patient. Now we'll look at the contraindications, adverse events associated with Secukinumab, and other interleukin-17 inhibitors. And this part of the presentation will be quick because we have already discussed a lot of adverse events with the previous presentations on different biologicals. So remember that all infections, any active infection is a contraindication. Any hypersensitivity reaction, or let's say any history of anaphylaxis to any of the component of the vial. So patient might be okay with Secukinumab but might be allergic to other components, and there's a huge list of component which is present in the product insert, like sodium citrate, sodium carbonate. These are all molecules, and if the patient is allergic to any of those molecules, it can have a bearing on the injection. So make sure that there are no history of urticaria or angioedema. Any active infection like tuberculosis in our country, which is a very important infection, that has to be taken care of. GI. So it has been found in few case reports that inflammatory bowel disease is exacerbated while the patient is on Secukinumab. Or if you administer Secukinumab in a patient who has IBD, the IBD gets exacerbated. We'll discuss this in detail on the slide on IBD. Okay. Absolute contraindication. There as such no absolute contraindication apart from severe infection or anaphylaxis to Secukinumab or its component. And here we have again see a mention of Crohn's disease or IBD. Okay. Suicidal, self-harm ideation behavior or depressive episodes. This is much more related to Brodalumab, but we'll discuss this at the end. Now pregnancy category, the older category is B. Okay. So the pregnancy category is B. The newer one, there is no data available, but it has been documented as low risk because patients who have had to receive Secukinumab and found that they were pregnant had no bearing on fetal status or baby status. Now remember, animal studies cannot be done to such a good extent when we are discussing biologicals. Keep that in mind that if we are discussing any drug, the same drug can be given to animal and we can test what are the events or what are the effects of that drug in that animal. But when we are discussing biologicals, we are discussing protein molecules and it acts on immunoglobulins which are specific to us, specific to human species. And every species will have a slightly different immunoglobulin. And because of that, we cannot use uh, the same drug for animal studies. So all of this study data that we see in animals whenever biologicals are concerned, the biologicals are modified to work into the animal or the animal is modified to work with a human biological, and that is why the data is not that reliable. So in all biological presentations you will be seeing that no data is there, no data is there, but it has found to be safe because we are assuming that it will act like any other IgG molecule. Okay. So older pregnancy category B, newer one low risk, but there is not much data available. One of the major adverse events for Secukinumab is infection, and it has been found to range from 2 to 18%. But none of these infections necessitate treatment discontinuation. That means in all the studies that we have seen for Secukinumab, patients have reported infections like upper respiratory tract infection, pharyngitis, nasopharyngitis, influenza, UTI, bronchitis, but they were all milder category infections, milder intensity infections, and do not lead to discontinuation of therapy. We are clear on that? Now, just to add here a little bit, interleukin 17 has found to be implicated at mucosal surface. So, this immunoglobulin has been found to act a lot where mucosal surfaces are present and at the entry sites of the body. So, your mouth, nose, these areas are affected. So, when you block interleukin 17, you have increased infections of respiratory tract, URTI, not LRTI, URTI, pharyngitis, nasopharyngitis, influenza, urinary tract infection, okay, bronchitis. So these are all mucosal sites which gets infected because we are blocking interleukin 17. Now you understand the concept why these infections are very common or commoner as compared to other biologicals while we are using secukinumab. Similarly, candidiasis is another infection which has been specially reported with patients who are receiving secukinumab. Okay, so it has been reported in it has been reported in 1.7% of patients. It is dose dependent. That means the risk increases if you are using 300 mg instead of 150. But it also does not require discontinuation and requires treatment. The drug that is usually used is fluconazole. Dose ranges from 100 to 200 daily doses for 1 to 2 weeks. But it's separate for pharyngeal candidiasis, oropharyngeal candidiasis, esophageal candidiasis, vaginal candidiasis. So there is different dosing regimen, but with normal regimens of fluconazole, we can treat candidiasis. Other specific side effect for secukinumab is neutropenia. Now, remember that interleukin 17 plays a very important role in movement of neutrophils in the body. Okay, and you would assume that if neutrophils are not being taken out of blood vessels because of blocking of interleukin 17, it should increase the concentration of neutrophils in the blood. But remember that neutrophils themselves would have to come out of the bone marrow and then into the blood. Okay, so what I'm trying to say that interleukin 17A is needed for neutrophilic trafficking. So movement of neutrophils from bone marrow to blood vessels also require interleukin 17 signaling, and also interleukin 17A is required for granulopoiesis. So what is granulopoiesis? That means manufacturing of more granulocytes. So that is why when we block interleukin 17, more neutrophils are not made, more neutrophils are not transported from bone marrow into the blood, and that is why you have neutropenia. However, the incidence of neutropenia is found to be less than 1%. It is found to be mild, self-limited, transient and not associated with serious infections. So you may continue Secukinumab. Just keep an eye out on neutrophil levels. Okay. IBD. So in inflammatory bowel disease, it has been found that new cases of IBD develop when we are giving Secukinumab, or if there is a history of IBD, it gets exacerbated. So that is why now you remember why Crohn's disease or ulcerative colitis were found to be a contraindication while we were discussing the contraindication for Secukinumab. Okay. Now TB and Secukinumab. Remember to screen all your patients, but also it's an interleukin 17 inhibitor, so the reactivation of tuberculosis is not that much a risk as compared to TNF alpha. So it is better than TNF alpha. There have been 10 large studies of Secukinumab. I think some of the names are fixture, figure, transfigure, stature, erasure. All these are studies of Secukinumab. And in these large studies, none of the patients have reported a reactivation of tuberculosis or any activation of tuberculosis. So it is comparatively safer in patients as far as TB activation is concerned. So if you have a patient who has a latent foci of tuberculosis, it's a good idea to start with the prophylactic regimen, which is isoniazid for 6 months. And some books do mention isoniazid with rifampicin for 4 months. And I've also read articles in which they mention that 3 months of combined therapy of H and R is enough. Okay. So you start, in short, what I'm trying to say is start your patient on prophylactic dose therapy for tuberculosis and then consider giving Secukinumab. But remember, you have to screen your patients prior. Clear? So let's move forward. Regarding vaccinations, all pediatric patients, although it is not approved for any kind of pediatric indications, should be brought up to date with all immunizations. Patient may receive vaccines, but they cannot receive live vaccine. Okay, so no live vaccine. Remember, no live vaccines. Only killed vaccines or subunit vaccines are okay. But it has been found that even if you give killed or subunit vaccine, the seroconversion, that means formation of protective antibodies, has not found to be that up to mark as compared to a patient who was not receiving Secukinumab. But the protection or the data is not much available so that we can concretely say whether the seroconversion is hampered or not. But theoretically, the seroconversion is not up to the mark. Now, this is the shortest slide of the presentation. No drug interactions have been evaluated. Remember that the autoantibodies are not made, so methotrexate is not given with Secukinumab. Other drug combination with any other drug is not recommended and not studied also. But it has been said that it should not be combined with other TNF alpha inhibitors. Okay, and methotrexate or cyclosporin. These are all other immunosuppressives, and when you combine in interleukin 17A with other immunosuppressive, you may increase the risk of infections. And remember that URTA, LRTA, candidiasis are very common in Secukinumab as compared to other biologicals. So you'll be risking your patient. So it's better to give only Secukinumab. Clear? Not much data is present for its use in pregnancy. However, remember that it is category B and low risk. But like all IgG1, it passes through the placenta to the fetus, but it has not been found to have much effect on fetus. Now, lactation, there are no studies which mention that if Secukinumab gets passed to the baby through breast milk, but since the data is not there, it's better to avoid and to give when it is absolutely necessary, and always weigh the risk to benefit ratio while giving in lactating mothers. Clear? Now with this slide, we finished our discussion on Secukinumab, and on subsequent slide, we'll be just discussing other interleukin 17 inhibitors. They have not yet received FDA approval, but their efficacy in psoriasis are being documented by various other studies. And so we'll discuss one slide each on other interleukin 17 inhibitors, and just so that in the future, if they received FDA recommendation, so you must know few names of other interleukin 17 inhibitors for at least viva purposes. And if by chance in the future any of them receive FDA approval, We'll have a separate detailed video on that. Clear? Let's move forward. Other interleukin 17 inhibitors, one is Ixekizumab. So it's tough to pronounce. Thank God I'm doing only one slide on this. So Ixekizumab is a humanized IgG4 antibody. The dosing regimen is 160 mg subcutaneously at week 0, followed by 80 mg at 2, 4, 6, 8, 10, 12 and then 4 weekly. Just to remember, 2 doses at week 0, then 1 dose each at 2, 4, 6, 8, 10 till you reach 12 and then every 4 weeks. Okay, so in the event in the future, if Ixekizumab is approved, we'll have a detailed video on that. Now, responses are found to be better as compared to Secukinumab and etanercept. Okay, so whenever a newer biological comes, studies happen to compare it with TNF-alpha inhibitors, and we take etanercept because remember the slides on etanercept, it is one of the best acting TNF-alpha inhibitor. So we compare it with the best acting TNF-alpha inhibitor. So the response rate with Ixekizumab is found to be better as compared to Secukinumab or etanercept. Remember that PASI 75 scores at week 12 was 75 to 80 for Secukinumab. It has been found to be around 85 to 88 for Ixekizumab. Okay, so Ixekizumab is partially a bit better than Secukinumab or etanercept. So isolated case reports exist in which Ixekizumab is found to be helpful in pustular psoriasis and erythrodermic psoriasis. Okay, so that's it for Ixekizumab. Other is Brodalumab. Now the mechanism of action is a little bit different. It is a IgG2 human antibody, but it's a interleukin 17RA receptor. So interleukin 17 receptor A antagonist. Clear? Now let's discuss a little bit on what we mean by that. For Secukinumab, what Secukinumab was doing, it was binding the interleukin 17 and then not allowing it to attach itself to the receptor. That is how Secukinumab was acting. What Brodalumab does is it attaches itself to the receptor. It attaches itself to the receptor and then prevents the interleukin 17 from acting. So now you get the point. Secukinumab, let's take an example, you'll be able to understand. Let's say this Rubik's Cube is Secukinumab. Sorry, this Rubik's Cube is interleukin 17 and this black hand is the biological. The hand which doesn't have a glove on it is the natural receptor for interleukin 17. Okay, so let's say interleukin 17 is coming in circulation and it attaches itself to the receptor and this leads to inflammation and psoriasis. This is a normal pathway. Okay, this is Secukinumab. What it does is it catches interleukin 17 and doesn't allow it to get attached to the receptor and thus the psoriasis is mitigated. Clear? What is Brodalumab? Brodalumab attaches itself to the receptor and the receptor is occupied and thus it does not get attached to the interleukin 17 and psoriasis is mitigated. We are clear on that? Are we clear that Brodalumab is a bit different than Secukinumab? Secukinumab is going to block IL-17. Brodalumab is going to block the receptor A and thus the whole cycle gets disrupted. So let's keep it clear. Now this is the dosing regimen. I am not going into detail. If it receives approval, then it will be worth making a PPT on this. Now responses are faster. Remember that Ixekizumab responses were better. For Brodalumab, the responses are faster as compared to Secukinumab and Ixekizumab. Case reports exist in pustular psoriasis in which we actually want a faster response. Now this is one interesting point about Brodalumab, that it has a boxed warning for self-harm ideation and depression. Okay, and that is because few patients in the study, I don't remember the exact number, but they were like 3 or 4 patients who actually succumbed to suicidal ideations and succumbed to suicides. Okay, so that is why on every follow-up visit a recommendation has been made in the product insert, which is REMS. REMS is risk evaluation and mitigation strategy. So REMS is risk evaluation mitigation strategy, in which At every point of giving the drug, you evaluate whether your patient have any risk factors or not. Clear? So every time you will understand whether patient has any history of psychiatric disorders, any family history of psychiatric disorders, how is the mood of the patient. At every follow-up visit, you will ask what is the mood. Now remember that psoriasis itself is a disorder that might lead to depressive episodes and thought processes. And in the studies for Brodalumab and Secukinumab, it has been found that there is a good improvement in DLQI parameters. So when we treat psoriasis, the patient will feel better. But remember that Brodalumab is associated with ideations, and that is why it has a box warning against it. So in every follow-up visit, keep on asking this question and evaluating mood for your patient. So we're clear on that? So with this, I stop my presentation on Secukinumab, which is interleukin-17 receptor. Please make sure you go back and watch separate videos on each biological. I understand that these presentations are very long. Nobody wants to spend 1 hour learning about biological. But remember, if you listen to this presentation for an hour or for 50 minutes or so, you just have to listen to this presentation only. So when I make these videos, I read about 3 books, 3 different textbooks, 4 to 5 articles to compile it into one PPT. So that this is absolutely what you need. Just listen to it at 1.5 speed. I don't care, listen to it in parts, listen to it in full, listen to it while walking on your morning or evening walks, listen to it while you're cooking or driving or something else. Just listen it, keep it playing in the background so that some knowledge gets diffused passively. And I know that these presentations are long, but it's good that we learn about these biologicals in a sequential manner so that it's easier to remember. So if you have studied that presentation on pathomechanism psoriasis, now you will understand why TNF alpha inhibitors have increased risk of TB activation, why as we are going downwards and downwards, the response is getting better, why do we have auto injector pens with decreased bioavailability as compared to IV infusions, uh, why we have different efficacies with different biologicals because the therapeutic target is different. Ixekizumab has 2312, Secukinumab has 17. Okay, uh, we have other biologicals like Ixekizumab who have like interleukin 13. So these are all different biologicals which are acting on different chemical targets, and that is why the efficacy will be different for different patients, and you'll be better prepared in thinking what biological to give in your patient. Okay, so it's a good form of personalized therapy or a personalized medicine in which you take out all the factors which is present in your specific patient and then decide a good biological based on that. So with that, I'll end this presentation. If there are any doubts, any comments, any questions that you would like to be answered, or any other recommendation on what all should extra I should have covered, just mention that in the comments. I read all my comments. And with that, we'll finish this presentation. Adios. Next week, what we'll do is we'll complete this series by discussing all other biologicals. For example, separate interleukin 23 inhibitors, separate interleukin 12 inhibitors, any other biologicals which are used in psoriasis which we have not covered. The idea of making individual videos on these biologicals are that these 6 biologicals, Brodalumab, etanercept, Infliximab, Certolizumab, Ixekizumab and Secukinumab are FDA approved as of now. Okay, so that is why they have their individual detailed presentations. Next week we'll have a presentation on all other biologicals which are not yet approved, a quick run through of different biologicals, and with the next week's presentation we'll finish our series on use of biologicals in psoriasis, and then we'll think about something else. So adios, practice sun protection, use sunscreen, use umbrella, the end, and bye bye.